Hi, this is Tom at the University of Iowa. I'm going to show you a full case by Jojo Silverman, who's a wonderful resident in our program here at the University of Iowa. You can see it's a toric case, and we're marking for the 180 degree axis, and we'll deal with that later. But one of the great advantages of toric cases when you're getting started is that it helps you sort of locate what's right across from you, which is useful when we're doing grooving. This is me actually doing this from the superior position. What I'm doing is I'm just setting the depth with the crescent blade, and now I'm just going to make a little bit of an entry wound, because it's hard when you're just getting started to know the right depth to enter the cornea. And this is a nice trick to use with brand new surgeons. They're just getting started, just so they have a way to find that right depth easily. And now I'm going to be doing everything from the paracentesis for somebody with their very first case. And so I'm making this paracentesis. You can see I'm just using my finger to support the eye, but I'm just making a paracentesis here with an MVR style blade. And then usually I go ahead and place the substances for the first time. I'm going to place, in this case, the lido and epicaine. And I'm going to, this actually may be her going in with the viscoat. You can see she's having a little bit of trouble at first getting the depth just right and getting the toe enough down to get past decimates. But she gets in there with the viscoat and places some viscoat in the eye. And that's a fine amount. And now I'm just going to go in from superior and just place some Provisc, the cohesive viscoelastic for the Arsenough shell. And I'm going to come out and just make sure that there's enough in there. I want the eye really firm so that she can safely do the incision. And now she's going to do the incision. And again, we've already got the depth set with that little maneuver that I made with the keratome, the crescent blade. But here she's going to go with the keratome. She did a nice job of getting centered with this ring. And now all she has to do is just push straight in. Because we've already got the depth, she can bring the eye away from her, get her toe up, and because we have just the right depth here, she can just push straight ahead. And now all she's going to do is bring the eye towards her just a little bit, and again push straight ahead. Nice big formed eye, just push straight ahead and get all the way to the edges of the keratome, all the way to the edges, yep, and then come out slowly. It's a beautiful job for the very first time that she's done a live surgery with the keratome. So that was a beautiful job. There's a little bit of conge there that might balloon up, and so we made a little incision in the conge because she was a little bit posterior, but really a very nice initial incision. So now we're going to place some Ocucoat on the top, just because I'm lazy, don't want to have to give her too many drops, and a little bit of that Ocucoat to place in the wound. Just to give us a little bit more dispersive there. And you can see now she's probably looking over the cystotome and getting that squared away. We're probably doing some teaching about how to hold it at this time, and I think it's important to have your hands set up for the position that it's going to be in the eye, and then get awkward or turn your hand when you're trying to get in, so that then you're comfortable when you go back in again. And now she's gone in nicely. She's dimpled down. This is a retrobulbar block, but the patient's still moving just a little bit, as you can tell. And she's doing a decent job here. The main issue at this point is usually when residents with an N this low try to go down with the instrument, they just push straight down as opposed to sort of teeter-tottering. And so if you want to keep the wound stable, you have to lift up your hand in order to have the tip of the instrument go down, because there's a teeter-totter right at the wound. But it was a pretty good job, and we haven't lost that much viscoelastic, just a little bit. She does a nice job of pulling this over. This is a tribute to all the simulation work that she's done with Dr. Hogsdale prior to this, and she's done on her own. We use both the icy and simulated eyes for practice of the rhexis, and I think that was a really wonderful start, especially for an N of 1. That's just a wonderful start. So now we're going to switch over from the cystotome to the Utrata forceps, and she's practiced before on the icy, but of course the icy forceps are awkward. And so I just sort of showed her how to hold it, give her a sense for where to grab, and I sort of gave her a sense of what I wanted to do. Now I'm going to just be pumping the viscoelastic in here to keep it as safe as possible. I'm going to tee it up just a little bit better through the paracentesis, and we're going to go ahead and she's just going to try to get 90 degrees. And you can see that often in the case, folks will not set themselves up very well for the next step. But she did a decent job of setting herself up here. And it's one of the things that Dr. Hogsdale works on with them in simulation. But she could do a little better job, of course, with centration. She could do a little better job with setting herself up for the next step. But it's pretty darn good for the very first case. As a matter of fact, it's exceptional. And now, again, she just went on top to grab. You normally would set it up so that you could easily grab it. She's sort of venturing away a little bit, but now she's in a better position where she can grab it. And she wants to try to bring it around maybe another 45 degrees if possible. She's doing a nice job keeping it centered. Getting a little low on viscoelastic at this point, which is common. And so I'm probably pondering, should I add more viscoelastic or not? I don't want to interfere with her. But you can see she really did pretty well. I didn't have to add any more viscoelastic, and she got a nice continuous capsulotomy. It's very centered, it's very round. It's an exceptional first time. And I think that's a tribute to the simulation that she's done before, as well as her practice. And so you can see we're going to get the phaco ready. And in the meantime, she's going to be doing the hydrodissection. Hydrodissection is a tricky step for people. There's a tendency to have trouble. The cheek gets in the way. And this is just a regular cannula, so it's not a special cannula. So she has to go on the side. And so she's doing a little bit of teaching here. I'm just sort of talking to her about how she has to go on the side and can't go straight in, and showing her how to angle in there. And so it's worth, at this point, just sort of going over with her, showing how to hold the instruments, which is what I'm doing there. And as she's going in, she hasn't moved the eye over too much. She's not oar-locking too much, and she actually got a pretty immediate response there, which is pretty extraordinary. She's pushing the eye over just a little bit, which is common. And so I'm just telling her, hey, don't push the eye over. Try to keep that wound neutral. And that's one of the hard things that people have to learn when they're getting started, is keeping the wound neutral. I added a little more viscoelastic just to keep the eye formed while she's doing that. It was a cohesive viscoelastic, which is a good choice at this point. So she had some pretty good movement there. You know, I think that the thing that's interesting at this point is, you know, how centered can she keep the eye? How much oar locking is she doing? And I'm sure we're talking about these issues right now, and it's off screen, and you can't see what we're talking about, but I'm pretty sure that's what we're talking about. Now I'm doing the second instrument here. I'm going to use the Drysdale. I'm just going to see if it rotates, and you can see how nicely it rotates. And so we were able to easily rotate the lens. Now we're going to go in with the phaco needle, and so we're talking now about how to hold it. We're talking getting the needle squared away. Typically with first case, maybe through maybe the 10th case, I'll have folks go in with the bevel up, and then I'll assist them with the wound with a Drysdale or a second instrument, because it's kind of hard with the bevel up to get into the eye. The nice thing about having the bevel up is you don't have to spin it as you go in. And so that's why I like to start this way. And so she's just sort of talking to me about how to hold it right now, and what to do. I think that sort of how to hold the instrument is tricky because the simulated instruments are for the IC are not the same size, and so just holding the instrument, it feels so bulky and big at first. Although she does have, as I mentioned before, a fair amount of simulation practice. So now I'm just going to hold the anterior portion of the wound up a little bit while she goes in with the bevel up, And then she's not going to turn the fluid on until she gets in the eye because it keeps it thinner. And now she's going to turn the fluid on by just going to position 1. We have it set up so that the minute you go to position 1, the fluid is on until you turn it off. And so that's a nice way to have the settings. And you can do that. This is a Bosch & Lomb machine. You can also do it on the Alcon machine. Okay, let's get rid of that big bubble in the way. And now we're just going to sort of focus on our groove. And this is a fairly soft lens, so it doesn't have to be a wide groove. And the main thing that people do at first is they just have trouble getting it centered. And so that's one of the advantages of having the toric marks here, is she knows that needs to go just a little bit to the right. There was some issue with the instrument here, and so we actually came out for a while and had to prime it. And so the technicians were in training too, and so they had not primed the instrument yet, and so we had to get that squared away. And now we're going to go back in. But it did give us 2 opportunities to enter, and it gave us an opportunity to talk about the process of priming. And you can see there was some air because we reprimed there, but no big deal. And we're probably going to crank up the vacuum a little bit, put it on epi mode to get a little more vacuum, get a little bit rid of some of this debris in there. You can see already that she's doing a good job of moving the instrument without moving the wound too much, which is pretty remarkable. So in other words, keeping the wound still. So now we're going to go to our sculpt settings, which basically have a very low vacuum. This is a Venturi-based system, so it's just a very low vacuum. And she's going to aim for the other side of that mark, which will put her, right across from where she is now. And so now she's, it's always a little tentative at first. You're not sure how much is going to happen when you're stepping on the pedal, but now she moves forward with the needle nicely, stops before the rexus, which is nice. And the whole time we're talking about occlusion. This is when occlusion is so important. We don't want her to completely occlude because then things jump towards the needle. And so she's making an effort here to not occlude and not go into the anterior capsule. And you can see how really deliberate she is and how nicely centered this lens is, despite it being her first case of doing this, and I think that's remarkable. And so she's just naturally very good at keeping the wound stable while she moves forward. From the teacher point of view, you can see that we're talking a little bit during this and trying to give her a sense of how deep to go. And eventually she'll get so she only needs to make 3 or 4 passes, but in this case she made probably 5 or 6, which is no big deal. And now I'm going to go in with the chopper, and we're just going to rotate this lens. We just want to get it in half first, so I'm using a chopper, and you can see that this is probably a right eye, and so I'm just using a right-sided chopper. And so now she's getting what we call, marking the boundaries. So she's up there first, marking where she wants to go, and then she's coming from the center and coming up. And it only takes a few passes on the other side. So now we're going to work together. I just say, hey, just go in there and don't move at all. And so you can see she does a nice job of just going in there with the phaco needle and not moving. And now I'm going to, again, I'm doing all the second instrument stuff here. It's too much to start to do both the second instrument and the first instrument. At first, the staff should use the second instrument. And now we've got it in half nicely. And it's amazing, really. We're only, like about 12 or 13 minutes into this case, and she's already got it in half, which is pretty incredible. And so now we're going to just try to encourage her to stay in the pedal and to make a nice little side groove here. Usually we like to make 1 pass and then go the other side, just make it wider, make a second pass. The second pass wasn't so great, wasn't quite long enough, but she's going to recover quickly. So you want this to be a little wider than the other groove. You're just going to get rid of some of the lens material, and you're just going to make it so that there's less occlusion because it's wider. And so we're going to go in here, and now we're going to ask her to put the needle in. We're just going to, I'm going to do the second instrument, and you can see how nicely that split into 2. And now we're really making progress. And now she's already done 1 half, and this is a great opportunity for her to show that she learned what we just did. And you can see that she's just basically doing exactly the same thing, probably talking to her very little. And so she just really was able to do the same thing again. And so now we're going to, once again, crack it in two. And we decided just a little bit more might be useful. So she just did a tad more there. Probably not necessary. And now we're both going in the tunnel, and now we've got it into 4 nice pieces. So let's just rotate it around and rotate it around. Let's get something really free across from her. We're going to change the settings, and so now we're increasing the vacuum, and we're going to have it a fixed vacuum so that we can easily grab a hold of the piece and pull it back. So it doesn't really matter where she is in position 2. The vacuum's the same. And so we have a setting like that, and the vacuum's probably about 400 in this setting. And now I'm going to do this dry style a little bit. I'm going to help her a little bit, but most of it she's just going to step on the pedal and take it. So that's one of the quarters, very nicely done. The other quarter's right there. She's just going to go down and take the next one. I'm going to just make sure it's free, rotate it around, give her that target, and she's just going to floor it. Now this is a pretty safe portion of the surgery because we still have those other quarters down there. But you can see she's got some really good behaviors. There's very little anterior chamber movement or post-occlusion surge. Now I'm going to try to get out so that I'm not causing so many eddy currents coming to the. But you can see there's a little current coming right out now through the paracentesis just from me having my instrument there. I'm going to try to modify that a little bit here and see if I can get that to stop. Nope, still coming out through the paracentesis. So that makes the chamber less stable. Now it's kind of stopped. Now I'm ready to go in if I need to. And then right there I just decided, I'm just going to protect the capsule. I'm going to come out. She's going to come out. And that is just a wonderful nuclear fractus for somebody with an N of 1. This is the 1 right here. Now we've got to do the IA. Now she's done IA before because in our program we do something called backing in, and in backing in, the residents when they're first years or PGY2s, they do the back part of perfect cases. So last year JoJo was doing the back part of perfect cases with one of our chief residents, and so she's got some experience already doing this. You can see I'm actually reaching across and helping her find the position. And so I find this useful. You can do this very safely as the mentor, as the staff, and you can help her find the right spot. It's hard with words to guide people into the right position, but you can see you can just reach over there and help just a little bit her get in the right position. You just have to be careful that you can sort of talk out who's got the stick, so to speak, as they say in pilot training. And so we're gonna just work our way around. It's kind of a slow and steady, like 1 clock hour at a time sort of IA, but that's common for this stage. So there was an aggressive move there where she got about 4 clock hours, which is nice. She's getting the hang of it. She's really getting a sense of the depth. And usually it takes about 50 cases for people to really understand the anterior chamber depth. And so I think she's doing a really good job of just getting the anterior cortical material, trying to just have just enough vacuum to sort of dissect it forward, but not so much vacuum that you lose your grip on the piece. That's a lot of that's about occlusion. And so that was really wonderfully done. And you can also see just how little movement of the eye there is, compared to so many people when they're getting started. One of the things that I always ask for our residents to look at is when they look at our really superb surgeons like Dr. Hogsdale, who's in our program, and just watch how little the eye moves when she operates, and that's because she's got such good control of the wound. And with time, of course, JoJo will have the same thing, but really surprisingly little movement of the eye. She placed a cohesive viscoelastic. Now I'm going to place a dispersive viscoelastic right at the wound. Now we're getting ready to mark with the Henderson torque system. And I really like this system. We've used it for years at our VA. And it has 2 parts to it. There's this ring that you can see here. And you set the 0 and 180 little dots so you can see the purple going through there. And then you use this separate device here, and you mark the axis where we're going to leave the lens eventually. So we're just doing that. Typically in a first case like this, I would do that myself. And you can see I didn't do such a great job at first. We didn't get it marked so great, and I'm going to just do it again and get a good mark. So that's where our goal is for the lens. And now Jojo has done several lens insertions during that backing in process I talked about before. So placing a lens is not a new thing for her. But still, it's a toric lens. She probably hasn't placed a toric lens before. And so I'm going to hold the eye, and she's going to place the lens in this fully opened up capsular bag. You can see she doesn't quite rotate it in time, and so she ends up leaving the lens sitting up a little bit, but it's no big deal. It's trivial to rotate the lens, but the next time she'll rotate a little bit so that the lens is flat when it leaves. And now she's rotating a little bit. She doesn't want to go past the point where we eventually want the lens, and she's hoping that these haptics are going to disengage. And they're sometimes stubborn, especially that trailing haptic is sometimes really stubborn. And so what I usually do is just show folks this trick where you go in, you turn the Kuglen hook so that it's pointing towards the inside, and that's the thinnest area, and then you sort of find the gap between the optic and the haptic. And so now we're going to leave the lens in that position. And so as a trainer, you just want to have just be able to reach over and use the incision, or have a paracentesis that's easy, so you can do little manipulations like that. It's not worth this is not what she's learning now. Usually for when we're starting, I have her go in all the way, get underneath, and then go right to position 2 so that the fluid doesn't move the lens. But in this case, you can see there was a little bit of error there, which is one of the problems with that strategy. But at least she got underneath safely. The lens didn't move into a funny position, and so she was able to get under. Now she's going to get that air bubble. That's hard to do sometimes because you have to get your hand so low. So you can see she's having a little bit of trouble getting the instrument high enough to get the bubble, which is common. But the lens looks good. It's in decent position. You can see her wonderful rexus. She really did a beautiful job with this rexus. Again, this is her first rexus on a real eye. And now she's going to rotate a little bit. So she's in position 1, a fixed position 1, and she's going to turn this silicon sleeved IA down. This is a beautiful instrument from Bausch & Lomb, and we're going to get it right at the axis of our goal. And you can see that it's pretty close right there. And so now while she's in there, she's going to go to a lot of vacuum, and I'm just going to squirt through the paracentesis to set up little eddy currents inside the eye, which might dislodge a piece of lens material that was in a funny position, or at least set up different currents that might allow it to be discovered. And we've had this several times when at the very end of the case we've discovered this, and so we're doing this to prevent retained nuclear material. And now she's coming out. At this point in the case, as the instructor, usually I'll do the hydration of the wound, make sure it's perfect. She's watching right now. She's, of course, really glad it's over. She's checking the wound there a little bit. It was a beautiful wound. And now we're just got one more thing to do, and that's place the intracameral moxie. This is sometimes hard for trainees to do because they haven't used the paracentesis. It's so important to not deflate the eye because we have a fixed amount of moxie we're putting in. We're putting in 0.15 cc's of the right out of the bottle moxie, and so we don't want to waste any, and we don't want to deflate the chambers. So, but she did a good job of slipping that in there. Well, I just thought you might want to see a complete case with one of our wonderful residents. In this case, Jojo's first case, and hopefully it's useful to you. This is Tom at the University of Iowa. Thank you very much.